Thank you. Good morning, dear colleagues. I want to thank Aradar for their kindly invite. It's great to be a part of such a great faculty. And I think I got the most difficult speech because it's between the both speech of Dr. Van Dijk. So let's start. Why does anatomy matters? Because arthroscopy is the most anatomy-driven surgery, I believe, in the orthopedic surgery. We deal with a small joint volume. We got limited working space. There are too many neurovascular structures nearby. The portal accuracy determines the safety, and the orientation determines the success. So when we look at the surface anatomy, when we are dealing with the anterior part, the portal creation starts on the skin. We should check for the tibialis anterior, EHL, EDL, peroneus tertius, medial malleolus, and lateral malleolus. So when we begin with the anterior part, we usually use the standard portals, anteromedial and anterolateral portals. There are described accessory portals, but most of the time we don't use them. Generally, the most accessory portal we use is the accessory anterolateral portal for the surgery of lateral instability. So when we are dealing with the anterior arthroscopy, we first start with the anteromedial portal. We need to check the tibialis anterior muscle and the joint line. But when you try to find the anteromedial portal, I think the most easy way is the thing I learned from Professor Van Dijk. When you put your finger on the soft point, the midline which transects your nail is your anteromedial portal actually. And you should check for the saphenous nerve and great saphenous vein. And the most important surgical pearl is the dorsiflexion increases your safety. So don't forget that. And when you are opening the portal, when we use the incision, we just incise the skin, and then we go with our mosquito nick and prick. We are using the nick and prick technique just not to disturb the cartilage. So when we come to the anterolateral portal, I think most of the time we are lucky in here because the most risky part is the superior nerve, but it's the only nerve which you can inspect from outside of the body. So when you invert the foot from the fourth finger, you can see it. And you need to define the peroneus tertius, and then you got your anterolateral portal. So when we just check for the portal safety for anteromedial portal, you should be careful for the saphenous nerve, for anterolateral superior peroneal nerve, and we will see later for posterolateral sural nerve and posteromedial tibial neurovascular bundle. So when we enter the joint, as Dr. Van Dijk said, most of the time you see a great synovium on the medial side, and you can check for the tibial plafond and talardon. First, we introduce the needle. It's easy when you introduce the needle parallel to the joint line. After the joint line, you can go with a mosquito clamp, and then you can introduce your instruments from here. So first, you need to orientate, then you need to intervene. So it's much more easier when you got some kind of inspection, a systematic one. You can start from the lateral gutter, then you can check for the syndesmosis, central compartment, and medial gutter. It's much more easier when you got a systematic checking points like that. So when we come to the lateral point, we can see the synovium. We got the trifurcation with tibia, fibula, and talus. We got AITFL, we got ATFL, and we got lateral compartment. So the trifurcation is important because it's most of the time our gateways to syndesmosis. And when you find the trifurcation, you got your orientation. You can't lose your orientation there. So when we check for the syndesmotic anatomy, we can see AITFL, tibia, and fibula. And we can check from here the syndesmotic instability, the prop assessment, and dynamic instability assessment. Here on the left-hand side, you can see that our prop doesn't go much more proximal. But here, this was a patient which got her injuries 6 or 7 months later, and you can see she doesn't get the ATFL, and the prop goes far beyond the joint line. So when we come to the central compartment, we can see the tibial plafond, talar down cartilage, and here it's much most of the time our cartilage inspection zone. So when we come to the medial compartment, we can see the deltoid ligament, medial gutter, medial shoulder, medial malleolus, and here I think one of the most important things is the Harty notch, which is a critical landmark for our medial talar lesions. So this is some kind of widening on the anterior aspect of the tibia, and here you can introduce your instruments much more easier, and this place is most of the time the OCD lesions, which we see most of the time actually, and which this notch makes our surgery much more easier. Here we start from the medial gutter, we can see the deltoid ligament, medial malleolus, then we move proximally, we can see here the medial shoulder, and we can see the Harty notch. So when we come to the posterior endoscopy, we use the concept which was described by Professor Van Dijk. It's in the prone position, 2 portals, and we start with the posterior endoscopy. Then if you move to the ankle joint, it becomes the arthroscopy. So here, this time we start from introducing the portal from the lateral side. We start with the posterior lateral side. We mark our lateral malleolus, and we mark our Achilles tendon. The posterior lateral portal is just 1 or 2 millimeters anterior to this intersection, and we should be aware about the sural nerve and small saphenous vein. Then we introduce the posterior medial portal. Here you can see both of them at the same time. But here the risk is much more bigger. We got the tibial nerve, the posterior tibial artery, and our points are Achilles tendon and FHL. So we should never go to the medial side of the FHL because the neurovascular bundle stays there. Therefore, when you are introducing the probe at the first time, you should aim to the first web space. Then you introduce your camera, then you open the posterior medial portal, you got a 90 degrees connection between them, then you create your working space afterwards. And in the posterior arthroscopic anatomy, we can see the FHL tendon, and like the picture here, you can release them if there is any kind of stenosis. You can see the PTFL, PITFL transverse ligament, or with the picture in the below zone, you can excise the osteotrigonum here. So when you are dealing with the arthroscopy, even it's the anterior or the posterior, you should always be aware of the neurovascular zones, and you should be aware of your portal security. So you should create portals deliberately, maintain your orientation. You must follow a survey pattern to be systematic. You need to identify trifurcation and respect the FHL. So what are our pitfalls? It's blind portal creation. You can get any kind of complication with it, even the iatrogenic cartilage lesions or the neurovascular lesions. You can lose your orientation, you can misidentify FHL, and you can ignore syndesmosis. So what's the take-home messages? Portal placement is anatomy and it's very important. Trifurcation guides anterior orientation. FHL guides your posterior orientation, and most complications are preventable. And safe arthroscopy starts before entering the joint and continues with anatomic orientation. And I wish everyone a successful course, and thank you very much.